All right, so we are the Rona Bandits, and we had our patient John James. He had a spinal injury, and so this is just a generic timeline that we gave him over the course of a year, and we'll get into specifics later, but this is just an overview. So John James had a spinal cord injury. He is a 23-year-old Hispanic male. He was in a motor vehicle accident 4 weeks ago and was treated and diagnosed at Craig Hospital with a severed T3, making him a paraplegic. On top of that, he also had a left femur fracture and has been diagnosed with depression. He doesn't want to interact with friends, and the diagnosis has really hit him pretty hard. And so he is a lower middle class citizen with a low SES. His car was wrecked in the accident, but his mom does have a van, and she's been the one taking him to appointments and will continue throughout the course of the year for his rehab and whatnot. His mom is 46. She was a single mother and works as a waitress at Village Inn. She does not live with John currently. She has her own place, but she does come over every day and help out. John himself is a new grad. He got a bachelor's in SES to be a personal trainer and recently got a new job at Lifetime Fitness. He's been working there for 8 weeks and has health insurance through his employer. He currently lives with his older brother, Jose, who is 26 and works as a mechanic. And Jose has been helping him through the course of this diagnosis. They're still living together. John himself has $52,000 in student loans and is a first-generation student. He now has more medical debt that is accruing from these injuries as well. And he currently lives in Colorado Springs, so he's transferring care down from Craig Hospital in Denver to Colorado Springs, so there's less of a commute.
So the pathology of the spinal cord injury and the related comorbidities are, it's divided into primary and secondary injury. So primary injury is pretty much where the initial mechanical disruption of axons result from cord compression, and it interrupts the blood supply to the cord. And then the secondary injury refers to the ongoing progressive damage that occurs after the injury, so like swelling and all that. And then for his T3 spinal cord injury, it affects muscles in his upper chest, mid to lower back, abdomen, and legs, typically resulting in paraplegia. And these nerves and muscles help control the rib cage, lungs, diaphragm, and muscles that help with breathing. AD is involves stimulation of sensory receptors below the level of the spinal cord injury, and it is a condition in which your involuntary nervous system overreacts to external or bodily stimuli, which causes a dangerous spike in your blood pressure, a slowed heartbeat, constriction of your peripheral blood vessels, and other changes in the body's autonomic functions. And some of the comorbidities of a spinal cord injury include depression, which is like just from the shock of having a different lifestyle that you have to adapt to, disruption of individual growth and development. So not having that mobility anymore can really disrupt your growth. Altered family dynamics because you're living a very dramatically different life. Economic loss in terms of employment, so you might not be able to work the same job, and you might not be able to do a lot of the same stuff you usually used to do, and some financial instabilities from like hospital costs and physical therapy costs. All right, and then we have our first NCLEX question, which is: a client is admitted to the trauma center with a spinal cord transection at T4. Which of the physical limitations does the nurse anticipate with planning the care? Select all that apply. And the answer to this will be in the end of the PowerPoint. And NCLEX question number 2 is: a patient has manifestations of autonomic dysreflexia. Which of these assessments would indicate a possible cause for this condition? Select all that apply. That'll also be at the end of the PowerPoint. So some diagnostic and laboratory monitoring that is needed after the initial injury would be a CT. So that's like the preferred imaging to really diagnose and locate the degree of the injury. An MRI is a more in-depth imaging used to assess the soft tissue injury and like neurologic changes or the worsening of the neurologic condition. An ABG would be used to evaluate the adequacy of oxygenation and ventilation throughout the body. Lactate levels will be drawn in order to monitor the perfusion status, and it can also be helpful in the presence of shock. Hemoglobin and hematocrit may be measured initially and monitored as needed to direct or monitor sources of blood loss in case there's like internal bleeding. And a urinalysis would be taken to perform, can be performed to detect any associated GI injury. And then after, with the progression of the injury, you can have other tests and sort, like the assessment of pressure ulcers, which is known to trigger AD. Frequent repositioning helps promote blood flow. Blood pressure monitoring would be taken for AD to make sure that it's not going really high past the normal range. You want to establish level of function and control and make sure that doesn't deteriorate over time. You want to make sure that active range of motion exercises are used to increase blood flow and flexibility so you're not stiff. Pain management can be done with medicine, application of ice, massage, or nerve stimulation, and other methods as well. You want to increase levels of protein in the nutrition in order to promote muscle regrowth, because with a spinal cord injury, you have a lot of muscle degeneration, so it's really helpful to build that back. And it's important to have a special regimented bowel program and bladder regimen, because both of them can trigger AD, so it's helpful to know how to eliminate. And appropriate medical treatment for the disorder is, once to the hospital, we want to focus on stabilizing the patient as much as possible in order to get them with their airway, breathing, circulation stabilized, immobilizing the neck to prevent further damage with turns, establish good IV access to infuse fluids like normal saline or lactated ringers, assess for other injuries that you might not know is present, control the external bleeding if it's there, control pain so the patient is comfortable, obtain appropriate imaging like the CT and MRI I previously mentioned, and keep warm with thermoregulation. And people with SI benefit from rehab, including physical therapy, which is more toward muscle strengthening, communicating, and mobility. The use of assistive devices is great with wheelchairs, walkers, and leg braces. The use of adaptive devices for communication is helpful if the patient has struggles with using them. Occupational therapy is focused on the fine motor skills like holding a pencil and writing your name, techniques for self-grooming and bladder and bowel management as previously mentioned, and coping strategies for dealing with spasticity and leg pain.
All right, so an update. So John was determined to have a T3 spinal injury and was stable. He had no respiratory complications, and so he was able to be discharged to a rehab facility in Colorado Springs after staying 4 weeks at Craig Hospital. He moved to a live-in facility for 4 weeks until he transitioned to home health care. That was just to make sure he was able to continue with his PT and OT till he was able to manage more self-care at home. And he's been approved for a nurse and a nurse aide and has visits from PT and OT to the home. So John is going home with his brother and is being taken care of, Jose, his brother, as well as his girlfriend of 4 years, Lisa. He's no longer employed by Lifetime Fitness. With having an injury such as this, they felt that he was not able to perform the duties that he needed to, that he was employed for. So because of this, he's no longer on the health insurance that was employed or given because of his employment. So he's transitioned over to Medicaid. John was shocked by the initial diagnosis, as anyone would be, and has lost hope and does not want to interact. He's displaying social isolation, which has been difficult for loved ones, particularly his girlfriend, Lisa.
Okay, so we're going to go over a couple of the medications that John will be taking through the course of this transition. So docusate sodium, which is also referred to as Colace or Soflax, Ducal-Ease, a lot of things like that, is an over-the-counter medication that you can get at any grocery store. It's a laxative and stool softener. So our patient will be on the generic 100 milligram capsules twice a day to start. Normal is 50 to 400 divided between 1 to 4 equal doses. So this was an accurate diagnosis by the doctor. Adverse effects include abdominal cramping, diarrhea, excessive bowel activity, intestinal obstruction, and it could cause throat irritation, which leads us to very much considering these nursing assessments. So an electrolyte imbalance could occur with excessive use. That's why we also want him to drink plenty of water when he takes this medication. We want to assess for abdominal distension, presence of bowel sounds, and consistent bowel movements, and teach his friends and family to do the same thing. Assess and educate on normal color, consistency, and amount of stool is also a good idea here. This is a surfactant laxative, so it reduces the tension of oil-water interface in the stool, and it enhances the incorporation of water into the stool, so it causes the stool to soften. A big thing to remind him is that the onset is 24 to 72 hours after beginning the therapy, so it's not a right-away type of deal, and it interacts mildly with mineral oil. We want him to take this medication by mouth with a full 8 ounces of water to prevent dehydration. This medication should also be recommended not to take more than a week unless directed by the doctor, which his doctor has directed him to take it for more than a week. It can help with the occasional constipation, but with our client progressing to a bowel program, he will discontinue this medication after a few weeks. It's important to take this medication at regular intervals. It's also important that we educate him that laxatives can be used on a regular basis, but the bowels can become independent or dependent on them, and that creates a lazy bowel. So we want to encourage him to, yes, he's going to use this at first, but he will be transitioning. He starts this medication in the hospital. So our NCLEX question is here. A client is taking Colace. The nurse monitors for which of the following to determine whether the client is having a specific therapeutic effect from this medication. Next, we have Vicodin. So this is a prescription medication for her chronic pain combination. It's an analgesic and an opioid. It's for moderate to severe pain, 1 to 2 tablets, and then we're going to do it by mouth every 4 to 6 hours as needed. Acetaminophen is the big one we want to monitor. We cannot exceed 1 gram per dose or 4 grams in 24 hours. The maximum daily dosage should not exceed 20 milligrams in 24 hours for hydrocodone. So the adverse effects can come with lightheadedness, dizziness, anxiety, nausea, vomiting, upset stomach, constipation, headache, mood changes, dry mouth, and difficulty urinating. All those fun side effects that come with a narcotic. Nursing considerations, this medication does come with a black box warning. So we want to monitor for the addiction and the use of this, as also for respiratory depression and sedation. So this also could cause severe hypotension, again, causing an AD episode. We also want to monitor for the liver enzymes for liver failure because acetaminophen long-term use could cause this. So acetaminophen acts on the hypothalamus to produce antipyresis, inhibits prostaglandin synthetase, and hydrocodone is an opioid analgesic and agonist, blocks pain perception in the cerebral cortex, and decreases synaptic chemical transition through the CNS. So the onset of action, hydrocodone is generally 10 to 20 minutes as it is an analgesic. Acetaminophen is less than an hour by mouth. With IV, which he will not be using, it is 5 to 10 minutes, but he will be taking this by mouth. So the onset of action, we just talked about that. Also, a big thing that we wanted to point out is pain is a serious problem for many people with spinal cord injuries. Pain can occur in parts of the body where there is normal sensation and where there isn't normal sensation, which a lot of people don't take into account. We are going to be starting other methods to manage his pain, but this is used PRN for chronic pain, and he's also going to start this in the hospital. Our NCLEX question for this. A patient arrives at the ED complaining of back pain. He reports taking at least 3 acetaminophen tablets every 3 hours for the past week without relief. Which of the following symptoms suggest acetaminophen toxicity? And our last medication we're looking at here is citalopram, which is also named Celexa. It is a prescription medication, and it's an antidepressant and an SSRI. So John is going to be starting with a 20 milligram tablet once a day initially, but this could increase to 40 milligrams per day. We want to monitor this because it can cause QT elevation. So adverse effects, the most common occur with dry mouth, nausea, somnolence, insomnia, xerostoma, increased sweating, decreased libido, diarrhea, and rhinitis. The nursing considerations, this also comes with a black box warning for suicidal thinking and behavior, especially at first. We want to instruct the patient to take this medication as directed. So taking missed doses, you want to take them as soon as you remember. Unless it's almost time for the next dose, you do not want to double your medication. You also do not want to stop this medication abruptly because it can cause anxiety, irritability, mood, restlessness, change in sleep habits, headaches, sweating, nausea, dizziness, electric-like shock symptoms. all of that, and that's a withdrawal symptom. All of those are withdrawal symptoms. So also follow-up exams are very important. This will take several weeks to build up and see changes, so we really want to educate John on this. So the pharmacology is this inhibits the reuptake of serotonin in presynaptic neurons, little or no affinity for dopamine. It's an alpha adrenergic histamine or cholinergic receptor, and it allows for more serotonin to remain in the brain and regulate mood. The onset again is 1 to 4 weeks for depression. Full response may not be seen until 8 to 12 weeks of the treatment. So this medication he will start in his follow-up visit after discharge as the depression becomes more evident. Our NCLEX question for this: a client has been taking daily doses of Celexa for 6 months and has asked for information with the nurse about going off the medication. Which should the nurse emphasize in the information session?
All right, so we'll move on to the diagnosis section. So our patient is currently at the inpatient rehab facility, and our first diagnosis that we thought was priority is deficient knowledge related to insufficient interest in learning, as evidenced by hostile behaviors toward healthcare workers. So as the nurse, we're going to focus on the nature of the spoken and written communication when we're teaching the client. We also should be considering the context and the timing and the order of how this information is presented. He has just been given this chronic illness diagnosis, and we need to just consider that he is under a lot of stress right now. Maybe we should teach at a better time when he is feeling more apt to learning. Also, we should use very client-centered approaches that engage the clients in an active way versus passive. So we'll move to the next one. Our next diagnosis, JJ is still at the inpatient rehab, and he's feeling very depressed, and he's feeling very socially isolated, and he's doing that to himself. So our next priority diagnosis is situational low self-esteem related to an alteration in body image and in social role, secondary to functional impairment, as evidenced by patient's feelings of helplessness and underestimation of ability to deal with the situation. So as a nurse, we're always going to assess first. So we're going to assess the client for signs and symptoms of depression, and also immediately notify the appropriate personnel if he does have symptoms. We also need to assess the client's environment and his everyday stressors, and assist in identifications of these problems and offer options for resolution. Additional things that we need to do are that we need to identify these strengths, resources, and previously effective coping strategies together with the patient. We should also accept the client's own pace in working through this grief and through all of these crisis situations, and also provide information about support groups of people who have common experiences. All right, so our next priority physiological diagnosis is constipation related to neurogenic bowel, inadequate fluid intake, diet low in roughage, and immobility, as evidenced by a lack of bowel movement for more than 2 days, decreased bowel sounds, and palpable impaction. So our patient is in the inpatient rehab, and he has been given Colace at his follow-up visit. Or he's been given it at the hospital. So as a nurse, we're going to monitor these bowel movements, right? Including frequency, consistency, shape, volume, and color to establish that baseline function, so we can make an appropriate bowel training program to establish a new bowel routine as quickly as possible. Go to the next one.
Okay, and so for education, following up on what Kendra's saying, if in order for us to monitor all these things, and we need to really educate the patient about the importance of bowel programs and the different kinds that there are, because after this injury, I'm sure that he doesn't even realize that, okay, first of all, my brain's not going to be sending those nerve impulses or the nerve impulses down to my brain through my bladder, whatever, and that nothing's not going to be working the same anymore. So we really need to educate him and help him as much as we can in the importance about avoiding constipation. And so we need to teach him that how important fiber is and how it helps aid the digestive tract, and then about approximately taking in 20 to 25 grams of fiber, as well as educating him about fibers that or foods that are high in fiber, such as veggies, bananas, apples, and salad greens. However, we can do all these preventative measures, but if constipation does occur, then we need to teach the patient that we need to do whatever preventative measures we can until the constipation resolves. And so with his stool softener, we could either increase the dose that he's getting, or increase fluid intake, or increase his activity, but anything that we can do to help this patient get the constipation relieved. So following up with that, we have our next NCLEX question, and it is a 22-year-old woman with paraplegia after a spinal cord injury tells the home care nurse she experiences bowel incontinence 2 or 3 times each day. Which action by the nurse is most appropriate? So we'll give you guys a second to pause and pick your answer, and then the answers will be at the end.
All right, so our next diagnosis that we felt was very relevant because he has lost his psychogenic erection ability. So our diagnosis is sexual dysfunction related to alteration in body function, secondary to spinal cord injury, as evidenced by actual sexual loss of psychogenic erection. So as a nurse, we're going to assess and provide info for sexual dysfunction involving the person's partner in the process and evaluating pharmacological and non-pharmacological interventions. We also need to refer them to the appropriate medical providers for considerations of meds for erectile dysfunction. And then we also need to reinforce or teach the client about these sexual functionings, alternative practices, and AJ will talk more about this in the next slide.
Okay, so for education on sexual dysfunction, we really need to teach him that he may or may not be able to achieve or maintain an erection, and it's definitely not going to be the same as how it was before. And so also going back to constipation as well as even other aspects, that the messages from your brain cannot get through anymore. So every part of your body is going to be affected. And so we need to teach him that the penis may be getting longer and fuller, however, it's not going to be rigid enough for intercourse. And so there are ways, though, to still be able to achieve an erection through constriction bands, the vacuum erection device, or medications such as Viagra or Cialis to make the erection last longer and become more rigid. And then we also need to educate the patient about retrograde ejaculation, which sometimes due to spinal cord injury, it prevents the bladder neck from closing and semen will go into the bladder instead of out of the penis, which is what retrograde ejaculation is. And so we need to educate them that this is doing no harm to you and the semen just comes out when you pee. So we need to educate him that changes may be happening and that's okay. That's not going to harm him or affect anything. And then most importantly, we need to teach him that nothing is going to be the same with sexual function, with his body. It's all going to be new, but we need to teach him ways to adapt to these changes and being comfortable with your body. That yes, you may not be able to achieve or maintain an erection like you used to, but you are still capable of it. And then the more that he is aware of all these things, it may help him as well as satisfying his partner. And then towards the end, you may even find after all these years that parts of sexuality that you thought were important are no longer, that they weren't as important as you thought they were. So you can discover new things about each other.
All right, our next diagnosis is chronic pain related to spinal cord injury as evidenced by alteration in ability to continue previous activities and pain for a duration longer than 3 months. And that's why he's been prescribed the Vicodin. So as a nurse, we're going to assess pain intensity level using a valid, reliable self-report pain tool, such as the 0 to 10 numerical pain rating scale. We're also going to have him describe his prior experiences with pain, what has worked in the past, and any fears about addiction when he's on opioids, any worries or any anxiety that he might have. And we're also going to identify a comfort function goal that will allow this client to perform the necessary or desired activities easily. Next, we're also going to assess the impact of this chronic pain on his activity and sleep, and also instruct him that he needs to plan his activities around his pain. So we need to maximize on the times where he's not in pain to do the most activities for him so he can get it done. Also, like how Cassie talked about the black box warning with Vicodin, we need to assess for signs of opioid misuse when he comes in for his follow-up visits. So how we can do that is using random urine drug toxicology screening, pill counts, and a review of prescription monitoring databases. And we also need to tell them that this pain management approach is very multimodal, and we're going to explain to him all of the things that have been ordered, all the side effects, and all of the complications of the meds he's on.
Okay, and so like Kendra was saying, with the pain level of 0 to 10, we can get that baseline pain from him. And if his pain is ever above his baseline or it's way too much to handle, then we need to educate him that he needs to call someone right away and a healthcare team member, that we can get his pain resolved and that effective interventions may be taken immediately. And we also need to provide him educational materials on various aspects of pain control. And then we also want to educate him about the possibility of developing an opioid addiction. It doesn't mean he has a past. It doesn't mean anything like that, but just because he is taking such high doses that there could be a possibility. And then we need to demonstrate the use of appropriate non-pharmacological methods in addition to the pharmacological approaches that we're helping to control his pain with all the medications. So we can suggest things such as heat and or cold packs, distraction techniques. We could do anything, any hobbies that really calm him down and help him focus. We could do listening to music, watching television, what he enjoys that would help him with these non-pharmacological interventions for pain.
All right, so another patient update. So John was at an inpatient rehab. He is now at home. He's been home for 4 weeks. And Lisa has left John due to complications related to the spinal cord injury. The erectile dysfunction was a very harsh thing for her to overcome. And she does want children, and so the stress of the injury was too much for her to handle, so she has left John, leaving him in a more depressed state, and he actually attempted suicide by slashing his wrist. His brother, Jose, came home immediately after and called 911, and John was in the hospital under observation for 72 hours since it was an attempted suicide. He was discharged back home under close supervision with his brother, and he sees a psychologist once a week, and they altered some of his antidepressant meds.
All right, so based on that life update, our next priority nursing diagnosis while he was at home is ineffective coping related to loss of control over body functions and altered lifestyle, secondary to paralysis, as evidenced by verbalization of inability to cope, expression of anger or other negative feelings, refusal to discuss changes in function, and participate in social contacts. So we need to assess this patient based on his adjustment to changes in his body image. We also need to assess the impact of the patient's life situation on the roles and relationships that he has. And we need to encourage verbalizations of feelings and perceptions and fears to aid this patient in clarifying his feelings. And furthermore, we need to provide this patient with very factual information to help him cope with his diagnosis and to cope with his future. We need to provide him with realistic choices about certain aspects of his care. And we also need to educate him on behaviors that are acceptable with coping so that we can prevent ineffective behaviors such as smoking, drinking, or angry outbursts, making this problem worse. And we should also encourage family involvement to enhance this patient's sense of self-worth and value as a person. All right. So like Marissa said in our update, our patient has attempted suicide. So our next diagnosis is self-mutilation related to ineffective coping strategies, secondary to loss of important relationship and history of depression, as evidenced by vertical cuts on the left forearm. And our patient is now admitted to the inpatient hospital, and he's going to be here for 72 hours. So as a nurse, we need to provide medical treatments for these injuries while he's in the hospital. We also need to put him in a one-to-one constant observation room to prevent him from causing further harm to himself. We also need to assess his risk for suicide or other self-damaging behaviors while he's in the hospital. And really, most importantly, we need to establish trust, listen to the client, and convey safety and assist in developing positive goals for the future.
Okay, so for education on self-mutilation, that we really need to teach the patient from the beginning that depression and anxiety, as well as numerous amounts of emotions, are going to occur. This is a huge life change, and he may not be able to handle it the way that he wants, but that these feelings are all normal. However, if he does have any of these feelings about him self-harming, and even furthermore after this, that he can confide in us, and that any thoughts that he wants to discuss, he can discuss with his healthcare provider, and we can get him the proper resources that he needs, that he's not alone, he's not doing all of this. It might be a new change, but that he can always come to us. And then we also need to teach him that meaningful activity once discharged is the best way to prevent boredom, depression, and suicide. You don't want to just go home and sit and do stuff that when you're just sitting there thinking about stuff, and then it's really going to get in your head, but just keep yourself busy and always be active, and that'll be a way to help you. Okay, so NCLEX question number 7. In planning care for a suicidal client, which correctly written outcome should be a nurse's first priority? We'll give you guys a minute to pause and answer.
All right. So now we're at 8 months in and our patient is back at home. He's been seeing his psychologist every week and he is ready to enhance his knowledge. So our next diagnosis is readiness for enhanced knowledge as evidenced by expression of desire to enhance learning, secondary to a suicide attempt. So we're going to seek those teachable moments for those with chronic conditions to enhance their knowledge of health promotion. And we should also consider motivational interviewing, which seems to be the big thing today, so that we can focus on his health-related goals, his priorities, and his preferences. We should also refer him to health promotion resources delivered in his home or delivered to a workplace or a community site that's accessible to him. And we should refer him to technology resources as appropriate. All right, and now we are at 11 months in. He is ready to live independently and on his own at home. So our last diagnosis is readiness for enhanced self-care as evidenced by expression of desire to enhance responsibility for strategies for self-care. So we're going to conduct mutual goal setting with him while we're in his home. We're also going to support the person's awareness that enhanced self-care is achievable, desirable, and a positive life goal. We're going to show him respect no matter what. And we're also going to promote trust and enhance communication between the person and his healthcare providers. And we're also going to help him set his own personal goals that he wants to achieve living independently.
Okay, so like I was talking about before, whether it's self-mutilation, whether it's constipation, no matter what, like he isn't going to be able to call these people and reach out if he doesn't know who they are, who to get in contact to. So I've just provided some resources that he could call. So for example, like the self-mutilation, he could have called the National Suicide Prevention Line. If he's unsure throughout the diagnosis and he doesn't want to keep calling the hospital, he doesn't want to go back to Craig, he can visit the American Trauma Society. He can go to the National Spinal Cord Injury Association. And each one of these websites helps a patient in a different way. And also we've gotten a lot of positive feedback that Christopher and Dana Reeve Paralysis Resource Center is very, very good, and it's very uplifting and positive, and it provides a lot of information that can help spinal cord injury patients. And then here's just a few more. So Craig Hospital is where he was if he ever needs to get back in contact with them or has any other questions. And then the United Spinal Association Peer Support Group. When I was researching, I had nothing. This was the number one that's saying that peer support groups are the best thing, because it's not like, hey, I'm not talking to someone above me. I'm not talking to someone who knows more. I'm literally talking to someone going through the same exact thing as me. And it provided the most positive and encouraging feedback that I had seen when researching this. So he could visit that if he's ever in question about anything else too.
All right, so some patient and family needs. So he is a Hispanic man living in America, and so with that cultural difference, he relies heavily on family support. He has a large family, extended. He has his brother and his mom as his central unit, and he finds balance by being connected to them. He is of the Catholic religious belief, so he does find strength in those beliefs and in that community. And it is a maternalistic society, so his mom tends to take care of everyone. She's got her hand in every pot, and she helps out wherever she can, including with all of his cares. So the patient does lose hope because of this injury and depression, but he does find faith in his church and his family, and that's where he gets his strength. Some things that we do need to consider with him are food education. So some of their cultural dishes are very fried. So teaching them how to have healthier alternatives, using less sodium, less cholesterol, as well as the language barrier. So he does speak English. It is broken though, so he may need a translator for some of the medical things. And his mom is English speaking as a second language, but all of them could need a translator as well. There is also distrust in the medical community with those of Hispanic background. So healthcare needs to be consistent. The same PT and OT going to help him, the same nurse, the same CNA. Building that trust and that rapport is very crucial for them to be able to follow those programs, as well as family and individual therapy. So him seeing the psychologist is kind of taboo. They're taught things need to be taken care of at home and with family members. So it's not very accepted, but from the suicide attempt, his family did deem that it was necessary. They just don't like to discuss it. As well as the suicide attempt, it's seen as taboo. It's not discussed. The family kind of sweeps it under the rug, for lack of better words, making things sometimes worse for the patient because he feels like they aren't acknowledging how severe his depression was and things like that.
So standards of care are specifically for spinal cord injuries. We've included all of them here. There are specific standards of care across the board for both acute care and rehab, some of the things that the healthcare team is going to be responsible for in all spinal cord injuries. So we're going to talk about those here and relate which ones are specific to John. So in the acute care setting, in the acute care setting, immobilization is one of the important things to talk about. So we want to ensure proper alignment of the spine and avoid skin breakdown. One of the strategies we use is a TLSO body jacket, and we just want to make sure that's not too tight on him, that there's no loosening or tightening of the straps that's either going to make the immobilization ineffective or cause skin breakdown. Respiratory distress is another important one we look at, not specifically for John because he didn't have any issues with his breathing after his injury, but even with a T3 injury, even though John didn't have anything, it's also possible that other patients may not be able to breathe initially due to the shock. So always monitoring respirations, rate, work of breathing, oxygen levels, ABGs, skin color, and if necessary, we would prepare for intubation and then wean the patient off of ventilation as soon as possible.
We also want to make sure to monitor their cardiovascular complications. We want to monitor their heart rate and blood pressure. They both can be low, which can cause orthostatic hypotension, or unopposed vagal stimulation. We also want to monitor their hemoglobin and hematocrit due to blood loss at the injury site, and these patients are at risk for thromboembolic disease. So nursing research shows that using prophylactic SCDs and low molecular weight heparin are a good way to prevent the formation of DVTs.
So some more acute care standards of care. Pain management is really important, like we talked about earlier, for patients with spinal cord injuries. We want to avoid bowel and bladder distension, which is a kind of uncommon thing with pain. We want to make sure to focus on that. And then we want to treat neuropathic pain. Like we were saying earlier, pain can exist in the areas that are affected by the spinal cord injury, even if they can't necessarily move that area. Sometimes they can still feel pain in that area. So it's important to monitor that. Skin is always a standard of care. We want to prevent pressure ulcers. We want to prevent any sort of skin breakdown. And then GIG was specifically important, not with John, but in some spinal cord injury patients, parenteral nutrition is needed. Like we talked about earlier, high calorie, high protein to promote healing. We want to insert an indwelling catheter, at least at first, until we get on a bowel program or a urinary program for him. And then we also want to do CODI prevention as well. We don't want to give him any sort of infections, and then starting a bowel program for him as well.
And we also want to make sure to consider their psychological information. Patients in the acute care setting with spinal cord injuries, when they are previously healthy, can find it very hard to retain information regarding their new normal. So encouraging a support person to be with them in the hospital is an extra way to make sure that your education is effective. And then our final NCLEX question is, a nurse is caring for a patient admitted with a spinal cord injury after a motor vehicle accident. The patient exhibits a complete loss of motor, sensory, and reflex activity below the injury level. The nurse recognizes this condition as which of the following? So, and as John transitions over to rehab care, we want to continue to monitor his respirations, especially during increased activity levels. And respiratory complications can be a major cause of mortality and morbidity in spinal cord injuries. So nursing research shows that using inspiratory muscle training to improve pulmonary function is a good way to minimize that effect. And we also want to continue to manage his chronic pain. And some new research is showing that in patients with spinal cord injuries, using cognitive behavioral therapy can help reduce the amount of times that patients ask for their opioid refills.
More standards of care in the rehab facilities include skin care, like we talked about, even in acute care, consistent cleaning, repositioning every 2 hours in bed and 15 to 20 minutes in a chair or wheelchair, avoiding any sort of thermal injury. GIGU, again, we want to avoid the neurogenic bladder, so we taught John specifically how to intermittent catheterize himself. And then we want to avoid the risk for neurogenic bowel as well, so we have the bowel program for him. And then we can also, if there are complications, use PR and suppositories. And then psychological, it's important to monitor for signs of depression, even at rehab facilities, even when they're kind of more focused on the physical, like making sure he can go back to his normal, as whatever his new normal will be. We want to make sure that his psychological is addressed there as well. And then quality indicators and safety considerations, we pulled these directly from the ANA, and they're kind of split up into 3 sections: patient satisfaction, safety considerations, and the nursing satisfaction, facility considerations. So within patient satisfaction, we want to talk about pain management, nursing care, so how do the nurses do overall care of the healthcare team, medical information relayed. Safety considerations include pressure ulcers and falls in both the acute care and the rehab care settings. And then for nursing satisfaction and facility considerations, we talk about nurse job satisfaction. How did the nurses think their job is going? Rates of nosocomial infections, and then total hours of nursing care for each patient. So how many hours did a nurse actually spend with their patient while they were in the facility? So then we kind of have some updates. Quality indicators and safety considerations specific to John, and each section is the acute care setting is the first one, and then the rehab setting is the next one. So at Craig Hospital, John used the HCAP survey, and he said that the nurses did a really good job there. He rated the overall facility as a 9 out of 10, saying that his mental health, he didn't feel was fully addressed there. But everybody did a good job of explaining his condition and the medications that he was being put on from that setting. He didn't use the survey in the rehab facility, but he didn't have as good of an experience at the rehab facility. He felt like his psychological needs were not being addressed at all, and he did have the tendency to self-isolate even at the rehab facility. And then safety considerations in Craig Hospital, there was a stage 1 pressure ulcer that developed, but they caught it pretty quickly and were able to treat it, and it resolved within a week. And then at the rehab facility, there was a fall that occurred due to a nurse not getting the proper assistance when working with John. And so that occurred, and it resulted in no injuries to John, thankfully. But he did note that that was a problem in his safety considerations. And then quality indicators, nursing satisfaction and facility, both at Craig Hospital and at the rehab facility, they both reported that there seems to be a shortage of nurses contributing to negative outcomes on patient care, which could have actually contributed to the fall that John had while he was at the rehab facility. Craig Hospital has a low rate of nosocomial infections. John didn't obtain any there while he was at Craig Hospital, no nosocomial infections whatsoever, even with the use of the catheter.
All right, so our 12-month patient update. So John has recovered full motion of upper body and extremities. Things were all affected initially with the shock of the injury, but he has full dexterity. He's using his upper body as he normally would. He's received a modified vehicle to be able to drive himself around without the use of his legs. And he's been dating his new girlfriend Maria for 2 months. It's been going well, and he has been able to achieve a healthy sex life through the use of Viagra. He actually won the spring 2020 lottery, so things are looking up for him. He received $1 million, so he's now debt-free from his student loans as well as some medical bills that he had acquired from this injury the past year. He reports that his depression is controlled through the use of medication. He performs upper body and abdominal weightlifting exercises and has taken up healthy cooking habits. John has become recently employed with Springs Ranch Elementary School as a PE teacher. He loves working with the children, and it's another way to get physical activity, but in a more in an environment that he really thrives in. And he attends St. Mary's Cathedral every Sunday and has taken a position as a youth director. And his old girlfriend Lisa regrets her decision. So these are some of the references that we had and used along the way, and then the answers to your questions. All right, that's it. Thanks, guys.